You are going to observe and participate in a clinical encounter of a 50-year-old man who comes to the office with a complaint of acute low back pain. As you observe the encounter, you will be asked to answer questions while the image on the screen freezes. These questions will allow you to practice the skills of history taking and physical examination, as well as clinical reasoning, as you develop your assessment or differential diagnosis and a plan, that is, an appropriate next diagnostic workup. You will have time to record your findings and receive feedback.
Mr. Randolph, what are your special concerns today?
Doctor, my back has been hurting for 3 days. I bent over to pick up something in my print shop and had this pain in my back that's so severe it's hard to stand up straight.
What clinical conditions are you considering at this time? Acute low back pain, herniated disc, spinal stenosis, compression fracture, trochanteric bursitis.
Can you tell me more about what happened?
Yeah, I was picking up a piece of equipment off the printing floor. I leaned over to pick the box up, and it wasn't heavy, about 10 pounds or so. And suddenly I felt this pull and this sharp pain right here in my back. It's like a band going across there.
Okay. And I see that you're pointing to your right lower back area. Can you tell me more about the pain?
Oh, well, it's off and on throughout the day, maybe 4 times, half an hour each, especially when I'm walking around. It's mostly a dull, aching pain.
On a scale from 1 to 10, 1 being mild and 10 being very severe, what would you rate your pain?
Oh, when I get it, it's a 7. It's pretty uncomfortable.
Can you tell me what makes the pain feel better or worse?
Well, it does feel better when I lie down, and I do feel better in the morning when I wake up. As for it feeling worse, bending over, sitting, or standing seem to make it worse. Oh yeah, and that walking around I mentioned.
Can you tell me more about walking or other activities?
It seems to hurt when I stand up and walk around. Even sitting sometimes can be a problem.
Does the pain move down into your leg?
No, not really. Just right here on my back and on the right-hand side here.
Does the pain move down into your lower leg or your foot?
No, not at all.
Any weakness or numbness in your legs?
No, my legs are strong. Just this pain right here on the right.
Now I'm going to ask you some questions that we call red flags. And this is just to see if there are any underlying conditions that we need to be concerned about.
Okay.
Have you noticed any difference with your bladder or bowel function?
No, that's fine.
Okay. Fevers or chills?
No, not at all.
And night sweats or weight loss?
No night sweats. I probably need to lose a little more weight. I probably could exercise more, but I haven't noticed any change in my weight lately.
Okay. Have you ever had cancer?
No, never had any cancers.
Good. You don't have any of the red flags that makes us think of serious causes for back pain. Do you ever wake up in the morning with a stiff back or stiff joints?
No, never had that.
And what about leaning forward or going uphill or upstairs? Does that make the pain go away?
I've tried leaning forward and backwards to see if it helps, but I haven't noticed much at all with changing positions, except when I lie down.
How about injuries to your back in the past?
That's the first time I've had a back problem.
Any other medical problems or surgeries?
No, my health has been pretty good. I did have my appendix removed when I was in the Army, when I was 22, but that's it for surgeries.
And what about your family's health? Has anybody had arthritis at a young age?
No, my parents and grandparents were all dairy farmers. They were pretty fit people. They mostly lived to be in their 70s and 80s.
Can you tell me what medications you're taking at the moment?
Well, none really. Just some acetaminophen that I've taken the past few days.
Well, how are you feeling about your job right now?
I've been on my job for the last 20 years, and I'm looking to get back as soon as I can.
And does your job cause you to do a lot of physical work or heavy lifting?
No, not really. Most of my job is spent at my desk, supervising, ordering, and maintenance for our printing machines. I really don't have to lift a lot at all.
What about depression or any problems that you're worried about?
Right now, I just want to take care of my back. Other than that, everything else is okay.
Okay. Well, we're going to give you a physical exam, but before we do, was there anything that we missed?
No, I think I've told you everything.
Listening to your story, there's a good chance your pain will go away, but let's be sure there are no concerning changes on your physical exam.
With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. What regions of the physical examination are important in this patient? General survey, check for pain behaviors. Vital signs, especially temperature. Abdominal examination. Musculoskeletal examination. Neurological examination, especially the lower extremities.
I see your blood pressure and heart rate are good. Your temperature and breathing rate are both normal. Your body mass index, which relates weight to height, is 22. Good.
Good.
Now what I need you to do is stand up for me and face away from me so I can examine your back.
Okay.
Okay, can you bend to the left and right for me? Okay, now bend backwards. Okay, now can you bend forward for me and touch your toes?
Ah, that hurts right there.
Okay. All right, now rotate left and right. Now I need you to walk to that wall for me, turn around and walk back.
Okay.
Any pain and weakness or your leg when you're walking?
No, my legs are strong. It's just that pain right here in the back on the right.
Okay, so walk on your heels first. Okay, now come back on your toes. Okay. This helps us check your L5 and your S1 nerve root. These areas are the two areas that are most commonly affected by herniated disc. Okay, so now I'm going to check your back.
Visually palpate the back.
Tenderness here?
Yeah, that's where it's sore.
Palpate the muscles. And percuss the spinal vertebrae.
Any tenderness over your spine?
No, not at all.
Okay.
Listen to the lungs.
Again.
Listen to the heart. Listen to the abdomen. Listen over the abdominal aorta in the epigastric area.
All right, so let me know if you feel any tenderness anywhere. All right.
Palpate the abdomen. Check the span of the aorta.
Any tenderness here as I check your aorta?
No, that's okay.
Okay, now I need you to roll over to your left side so I can check your sacroiliac joints.
Palpate the sacroiliac joints.
Feel any tenderness here?
No, that's okay.
Okay, so now I'm going to check here over your bursa, or your fluid pouch, over what we call the trochanter. Can you bend your right leg up?
Palpate directly over trochanteric bursa.
Any tenderness in this spot?
No, I don't feel any pain in that spot.
Okay, now how about lying flat again for me? I'm going to check your hips for arthritis.
Okay.
Okay.
Perform internal and external rotation of the right and left hips.
Now I'm going to finish your neurological exam and check your legs for strength, sensation, and reflexes. This will help me see if you have any disc problems or pressure on your nerve roots. Okay, so now we're going to check your psoas and your gluteal muscles. Can you raise your right leg up and press against my hand? Okay. Now press down. Okay, great. Now left side. Okay, now can you bend both knees for me and keep your feet flat on the table?
Okay.
Now we're going to test your quadricep muscles. I need you to straighten your right leg and push against my hand.
Like this?
Perfect. Okay, now let's compare this to your left side. Okay, so now we're going to test your hamstring muscle. Okay. All right, now pull down your foot and don't let me pull. Okay. Now left side. Okay, so pull your foot up. Okay. Now push against my hand. Okay. Now take your big right toe and push against my fingers. Okay, this helps us check your L5 nerve root. Okay, so now I'm going to check for sensation in your legs, especially in the web space between your big right toe and your second toe. This will help us test the L5 function. Let me know if you feel any sharpness.
Yeah, sharp.
Sharp?
Yes.
Okay, so now let's test your reflexes.
Check knee jerks. Check ankle jerks. Perform the Babinski test.
Okay, so for your last test, can you raise your leg up to here?
Perform the straight leg raise test.
Does this hurt?
No, that's fine.
Okay. Just to be thorough, I should check your rectal exam for tone. Sometimes problems in the upper spinal cord can cause referred pain to the lumbar area. Okay, so your neurological exam was normal, including your rectal. So now let's talk about your back pain and the next steps that will help.
List your diagnostic considerations in order of importance and explain your rationale. Press pause and list your answers. Resume when you are ready to receive feedback. Acute low back pain, present here, is generally defined as lasting up to 4 weeks. It is self-limited without an identifiable physiologic cause in roughly 85% of patients. This patient has non-radicular pain limited to the buttock area and a normal neurologic examination with no motor, sensory, or reflex deficits and a negative straight leg raise test. Current guidelines recommend using the history and physical examination, especially the presence or absence of focal neurologic deficits, to place patients in one of 3 categories: nonspecific low back pain associated with radiculopathy or spinal stenosis, or back pain associated with another spinal cause. It is important to identify red flags suspicious for spinal cord compression, risk factors for underlying systemic disease, and psychosocial features that could prolong recovery, such as depression, job dissatisfaction, and somatization. Red flags for spinal cord compression include bladder or bowel dysfunction, suspicious for possible cauda equina syndrome, fever, prior history of cancer, unexplained weight loss, no relief from bed rest, pain lasting more than a month, and age over 50. Disc herniation. Disc herniation with nerve root compression is the most common cause of lumbosacral pain with radiculopathy, characterized by pain radiating into the leg and sensory loss in a dermatomal pattern. Over 95% of disc herniations occur at L5-S1 at the acute angulation of the spine. L5 radicular pain extends from the buttock down the lateral leg, then anteriorly into the medial foot. For the S1 nerve root, pain radiates down the posterolateral leg and calf into the lateral foot. Here, disc herniation is unlikely, since the patient does not have radicular pain and his neurologic examination and straight leg test are negative. Spinal stenosis. Spinal stenosis arises most frequently from degenerative arthritis that narrows the spinal canal, either centrally under the facet joints or more laterally in the neural foramina. These changes cause nerve root compression, and the classic somewhat nonspecific symptoms of calf and distal leg pain during walking or prolonged standing relieved by rest, termed neurogenic claudication. Symptoms are made worse by leaning backward, lumbar extension, and improved by leaning forward, lumbar flexion, which appears to increase the cross-sectional area of the canal and reduce venous engorgement and nerve ischemia. This patient is 50 and has non-radicular leg pain, a normal gait, and back pain that gets slightly worse with forward bending, which makes this diagnosis unlikely. Compression fracture. Osteoporotic compression fractures often occur at the lumbosacral junction during routine activities such as bending, lifting, or even coughing. Often there is no trauma. At risk are patients with older age, previous fracture, low body weight, osteoporosis, and history of steroid use, excess alcohol, or smoking, all absent in this patient who is age 50. Kyphosis is a common hallmark. X-rays show characteristic vertebral changes of height compression, wedge shape, or biconcave deformity. Trochanteric bursitis. Patients with trochanteric bursitis typically present with low back pain in the buttock area or more laterally over the greater trochanter, caused by friction of the gluteus medius tendon over the trochanteric bursa. Pain can radiate into the knee or ankle, but not the foot. Standing up and prolonged walking makes the pain worse. Gait may be affected. At night, patients are unable to lie on the affected side. On examination, there is point tenderness over the trochanteric bursa with the patient lying on the non-affected side. This diagnosis is unlikely since the patient has a normal gait and no tenderness over the trochanteric bursa. List 5 next steps in your diagnostic workup. Press pause and list your answers. Resume when you are ready to receive feedback. Information about prognosis and self-care. According to recent guidelines, provide all patients with low back pain with information about the high likelihood of improvement, 50 to 75% at 4 weeks and 90% at 6 weeks. Explain that early imaging is not helpful in identifying the cause of back pain, does not improve outcomes, and increases exposure to radiation. Recommend evidence-based self-care books and provide advice about level of activity, which we'll outline later. Schedule follow-up at 1 month, but discuss indications for prompt reevaluation, such as persisting or increasing pain, infection, or progressing radicular symptoms like leg weakness or bladder or bowel dysfunction. Trial of appropriate medication. Acetaminophen is a reasonable first-line treatment up to a maximum of 3 to 4 grams daily to avoid liver toxicity. NSAIDs are the next step up for pain relief, but at the lowest effective dose, given risk of adverse gastrointestinal, renovascular, and cardiovascular side effects. Cautious short-term use of opioids or tramadol may be indicated for severe pain, but should be reassessed frequently due to the risks of abuse and dependency. Other evidence-based options include selected use of tricyclic antidepressants, benzodiazepines, and gabapentin, but not steroids. Tailored exercise program. Advise patients that remaining active is more effective than bed rest. Those at bed rest for severe pain should return to normal activity as soon as possible. Evidence suggests that supervised exercise, physical therapy, and home regimens are best reserved for pain persisting more than 4 weeks and are most effective when embedded in an interdisciplinary rehabilitation program. After recovery, many patients would benefit from exercise and weight reduction, since obesity and sedentary work are risk factors for low back pain. Other non-pharmacologic therapy. Evidence supports short-term use of heat, medium-firm mattresses, spinal manipulation. For chronic low back pain, defined as lasting more than 3 months, moderately effective interventions include acupuncture, individualized exercise therapy, massage, yoga, spinal manipulation, cognitive behavioral therapy, and intensive rehabilitation, but not traction and TENS therapy. Diagnostic imaging. Given the high rate of remission of low back pain, current guidelines strongly indicate that imaging should be reserved for patients with severe or progressive neurologic deficits and serious underlying conditions such as vertebral infection, cauda equina syndrome, or cancer with impending cord compression. Patients with persisting low back pain and radiculopathy or spinal stenosis who are candidates for surgery or epidural steroid injections should also be imaged. MRI is preferred to CT due to absence of radiation and better depiction of soft tissue, vertebra, and the spinal cord. In sum, the patient is a 50-year-old printing company supervisor with a 3-day history of acute non-radiating right low back pain, which occurred suddenly while lifting a 10-pound box of printing equipment. His pain is 7 out of 10 and improves with lying down. He has no leg weakness or numbness and no red flags for serious underlying conditions. He has no significant medical, surgical, or family history, and his only medication is acetaminophen for pain relief. His physical examination is notable for a BMI of 22, and right gluteal tenderness increased with forward bending. His neurologic examination is normal, with an intact gait and heel-and-toe walk. Rectal sphincter tone is normal. Diagnostic considerations include acute, nonspecific low back pain, disc herniation, spinal stenosis, compression fracture, and trochanteric bursitis. The diagnostic workup includes information about prognosis and self-care, trial of appropriate medication, tailored exercise program, other non-pharmacologic therapy, and diagnostic imaging when indicated.